That was awesome, and I am so excited to be here with y'all. My name is Cameron Berg. I'm an emergency physician from Minneapolis, and I'm going to talk to you about, for me, what has been the coolest thing that we've done during COVID. We're starting to send GI bleed patients home. This is a big deal. This is a big deal. So I'm going to talk to you a little bit about how we do it, go through the basic evaluation, therapies, disposition, follow-up. My goal is to leave you all with some ideas for how you could start doing this back in your own practice if you aren't already. And I want to bring some of the baseline evidence and talk about some of the outcomes that we're observing in real time. This is our most current pathway. It's like literally been live for the last 6 months, and I'm going to share with you all today our actual data. But before we get into this, personally, this is my first talk of this conference, I just wanted to pause and say, like, oh boy, is it ever good to be back with you all in a place. COVID was hard, I think, for a lot of us. Those of you who don't know, I got hit by a car. I had a whole bunch of injuries, totally unrelated to COVID. It was like a multi-year recovery. And you know, just being back here in Vegas with you guys in a room really makes a big difference. So thank you all. You are all our heroes in my book. We made it together. Like, we're here, we're doing it. And we're going to keep progressing emergency medicine towards new frontiers. So why does this matter? You know, one of my heroes of emergency medicine, Jeffrey Tabus, just talked to you, and I actually was thinking back towards like 15 years ago. I was listening to him talk about pulmonary embolism, and he said one of the most memorable things, which is it's our job as emergency physicians not just to know about the pathology we treat, but to understand it from the perspective of the specialists who will follow up those patients. And as I think back towards the practice changes that have occurred in the last decade or so, it's really been in those domains, right? We discharge pulmonary embolisms. We manage them with DOACs. We understand how to evaluate chest pain. Like 15 years ago, we just got EKGs, troponins, and then admitted people to the hospital for stress testing. We don't do any of that things because we took charge of these pathologies. And GI bleeding, I think, is next on the tick list. So when it comes to GI bleeding, the cohort of patients that I'm talking to you about today are those who you believe have a presumptive upper GI bleed. Now, I can get really pedantic. We can all go back and go through like the 5 things in the differential. It's pretty darn straightforward. You guys know this. If it's melena or hematemesis in an otherwise well person, that is very likely to be an upper GI bleed. And we have done inter-rater reliability, and the kappa value for this is like more than 0.9. Like, ED physicians are very good at identifying upper GI bleeds. That's what I want to leave you all with. When you think it's an upper GI bleed, it is. And I'll show you some substantiating statistics to go there. Those of you who followed my material over the last number of years probably know I'm oftentimes quite austere in my recommendations around labs. This is not a case for that. Get your CBC, your chemistry, and if you're even a teeny bit worried, get LFTs and an INR, okay? LFTs are a very good way of getting somebody's overall protein synthesis function and understanding whether there may be a more substantial underlying coagulopathy. Y'all know how to look for the crucial clinical features, okay? If there are red flags, this is not a kind of GI bleed patient to send home. The therapies, I want to disambiguate those because I think we all have made GI bleeding way too complicated. I think back to medical school and it was like 2 large bore IVs, we got to get type and cross, we got to get things going in the lab, we got to start the Protonix drip, and then is it bolus in a drip, and then like some octreotide and maybe antibiotics for... That's all nonsense, okay? It's PPIs, that's it. That's the only therapy, oral, IV, it makes no difference. No infusions, just a bolus of a PPI. That's like 40 milligrams of omeprazole once a day if you want to pick a cheap and generic thing. Now, when you're sending somebody home, it's also incumbent on you to modify the modifiable risk factors that will cause them to continue bleeding. And so what do I mean by that? Go ahead and wade in to the medicines that y'all don't normally like to play with. Turn off their antiplatelet and antithrombotic medications if you can, and all the other things, somatostatin analogs, IV PPIs, H2 blockers, erythromycin. Nope, we're not talking about those. Low-risk GI bleeds don't need any of those things. So when somebody does go home, and they're going to go home after about 2 hours in ED with you, okay? This is no like long structured evaluation. You get your labs, you get some blood pressures, you maybe have them on the cardiac monitor to make sure they're stable, and then you send them home. our system has been able to partner with a local gastroenterology group where we can get structured follow-up for these patients digitally through the EHR. I would love to talk to you all about how you can make that happen, because it sounds like a dream, but it isn't. Okay, I work in a community hospital with a community GI group that is trying to make money, just like the kinds of places where you all work, but you can make this happen. They go home, they're followed up within 5 days. We have a 24/7 call line where they can call back with concerning symptoms. We go through typical return precautions, but basically they go home and then they get a call from the GI clinic to set up a structured endoscopic evaluation sometime in the next 5 days. It's really not that complicated. The cornerstone of our risk evaluation is the Glasgow Blatchford Score. Many of you have probably heard about this. It's been out in the literature for 15 plus years. It's been formalized in European guidelines for more than a decade. This has been the cornerstone of how the UK manages pathology for the last 8 years. And so I just want to put this up here and highlight a couple things. We are talking about patients who score a composite GBS that puts them in the very low risk category, which means a 0 or a 1. And so just gestalt these for a moment. You have to be pretty darn healthy to score a 0 or a 1. Of our total denominator of patients presenting with presumptive upper GI bleeds, this is about 30%. About 3 in 10 patients are eligible to go home. They need a normal blood pressure, normal heart rate, no really concerning history, and functionally a normal hemoglobin and BUN. That's basically the cohort of patients we're talking about here. And when you do send them home, there's a couple of other pearls that I would like to suggest, and that is to use your gestalt as to whether somebody is reliable and has a physiologic reserve. The real reason why this pathway is safe, and I will show you the data momentarily, is because these patients, if they do deteriorate, don't deteriorate rapidly. They have a period of time. They are not coagulopathic. They are not cirrhotic. They do not have varices, right? These are largely esophageal disorders, gastric lesions, ulcers, and Mallory-Weiss from preceding vomiting. These are pathologies that are largely stable in the subacute time frame. Addressed actionable etiologies. I think this is where we sometimes sell ourselves short. We say, oh, I don't want to touch those PTA meds, even though it includes like dual antiplatelet therapy. Not a great move to send somebody home on dual antiplatelet therapy for an endoscopy 4 days from now, okay? It's all right to stop those meds. That's exactly what would happen if you put them in the hospital or if you referred them to home. And then, broadly speaking, this is our diagnosis to own, okay? I am showing you the best literature from the best sources, and these patients are safe if you do this in a structured evaluation. What I would really like to encourage you all is if this is the kind of interdisciplinary pathway that piques your interest, consider starting locally at your shop with a non-controversial population. Like Glasgow Blatchford Score 0. We have 20 years of data showing that these patients do well, and then you can scale from there. My favorite part of Essentials is when I can show you like real pre-published literature. So this is our actual outcome data. This is, I think, I literally looked at this yesterday. We have more than 100 patients who've gone through the pathway. We have a 5% ED representation rate. None of them have needed to be admitted. And so far, we have 85% adherence to the structured follow-up. That's all actually quite good. We are following these patients prospectively in a database, and nothing bad has happened. Again, we're talking about low triple-digit numbers so far. Where are we going next? Our intention is to expand this towards the Glasgow Blatchford Score of 2. Now, patients who score a 2 almost certainly need a brief period of structured monitoring. We're probably talking about like 12 hours in the hospital, and then they're going to need closer follow-up, probably like 2 days. But what I am most excited about with this is the GI team now loves us. Now we can get outpatient endoscopic ultrasound. We can do outpatient ERCPs, MRCPs. We can do anything because we're trusted colleagues in the risk stratification of GI bleed patients. To conclude, I put our actual pathway up here. It's also in the syllabus. You can go ahead and repurpose this. Just please credit my institution. And if you have any questions about this, I would love to speak with you more about them.